Hello, my name's Catherine from In the Mess. Picture this. A nurse approaches you worried about a newly admitted patient. You're not yet familiar with the patient as you've just come onto your shift. The nurse tells you they've just spiked a fever. What do you do now? So first, you walk towards the patient's bed. You're going to look around. Is the patient looking well, sat upright, or unwell? Are they on oxygen? Are there any sputum bowls? Are there any visible interventions such as a catheter bag or a drip set up? Now that you've had a good look around, you can move on to A, airway. Are they talking to you? If so, that tends to be a pretty good indication that their airway is clear. However, if they're coughing or struggling to breathe in any way, you should investigate this more. Our patient is sat up and able to chat to us in full sentences. B, breathing. There's a few things to consider in this heading. You want to know the respiratory rate, the character of their breathing, any cyanosis or cough, and see what their oxygen saturations are looking like. And now we look at the trachea. There's no deviation, and so we continue with our respiratory assessment. Here you want to feel the chest expansions and percuss and auscultate. Circulation. Start with the peripheral capillary refill by pinching their finger. Then I check the pulse with rate, rhythm, and character. Get IV access, popping on a blood pressure cuff, and then performing a mini cardiovascular exam as you reach the torso. You find no issues with circulation and reassess the interventions you have made. So moving on to D, that can be disability or don't ever forget glucose. So here you can move on to a rough scoring of the patient's level of consciousness. ACVPU. How the hell do you say that? AC. What is it? ACV. Why is this causing so much issue? Right. ACVPU. That's alert, confused, response to voice, responds to pain, or unconscious. Here I can also assess any other disabilities they may have. Our patient has a normal blood glucose and is alert. You may want to ask if there's any pain anywhere. This may give you clues as to the potential cause of the pyrexia. And if they do have pain, you can make them more comfortable by arranging pain relief whilst you continue with your examination. We seem to be running out of ideas as to what could be causing this pyrexia. Nevertheless, we move on to E. So E stands for everything else, or exposure. In a fever, there are a few specific things you want to look for. So in E, exposure, you particularly want to look for any rashes, or even skin infections like cellulitis. Remember, during your A to E, you can be asking patients and their nurses about symptoms. Have they had any diarrhea or vomiting? Have they been particularly lethargic at all? It just so happens that the urine dip for this patient comes back with positives for nitrites, leukocytes, and blood. We can send off a sample of urine for culture and start some targeted antibiotics according to the hospital local guidelines. Success. So what if it hadn't been a urinary cause for the patient's pyrexia? What else could it be? The most common causes of pyrexia are infections, but other causes can include heat exhaustion, sunburn, or conditions that cause inflammation, such as rheumatoid arthritis. You could also have vasculitis, might be a side effect of medications, vaccines or immunizations, and in some rare cases, it can be due to blood clots. Autoimmune diseases such as lupus and inflammatory bowel disease, cancer, hormone disorders such as hypothyroidism, illegal drugs, alcohol withdrawal, can all cause pyrexia. I hope this was useful, and if you liked this video, then please like and subscribe and share this with your friends.